this is a very broad topic. Basically, peritoneal malignancy means the malignancy which are spread through the peritoneum without any surface, without any deeper deposits. So these are also termed as peritoneal surface malignancies. The concept behind it is there are some epithelial malignancy. Most of them are epithelial malignancies which spread through the peritoneum in a systematic way, like ovarian cancer, colorectal, some form of colorectal cancer, gastric cancer. So in these patients, in where there is a isolated peritoneal metastasis other than the main primary organ, nowadays, after the Sugar-Baker concept has came, people consider peritoneum as a loco-regional organ rather than a distant spread. If you go through the staging of most of the cancers, the peritoneal metastasis is described as stage 4 cancer, and that is incurable or a distant metastatic disease. But with the concept of Sugar-Baker coming, more and more peritoneal malignancies are considered peritoneum as a loco-regional organ, like if a colonic CA spreads to the adjacent organ, so we stage at a T4, but we don't consider it as a, or to the lymph node, we don't consider as a metastatic disease. So nowadays, in some form of cancers, this peritoneum acts as a loco-regional spread. So if we can cure this peritoneal metastasis, maybe we can give these patients a curative intent of treatment. So that is why this peritoneal malignancies or peritoneal, pardon, am I audible to all?
Yes, audible, sir.
So that is when the peritoneal surface malignancy came into the picture. It is in the early 2010, 2012, that time, and that time in abroad as well as in India, people started doing these peritonectomies in some form of cancer. So now it has seen that some cancers like epithelial ovarian cancers, colorectal cancers, these cancers has a particular pattern of spread through the peritoneum. They start from the paracoelic gutter or the parietal peritoneum, goes to the right diaphragm along the peritoneal current, then it comes to the foramen of Winslow, and then it goes into the splenic hilum, and then through the left paracoelic gutter. So this is the normal peritoneal flow which is followed in this form of malignancy. So suppose this is your uterus and ovary. Am I screen visible to all? So now suppose this is a tumor, and this is the parietal peritoneum. So this is your right diaphragm, this is your left diaphragm, this is your left parietal wall, and now this peritoneal malignancy starts going from the particular primary organ through this right parietal peritoneum. It goes up to the right diaphragm, then through the foramen of Winslow, it comes to the splenic hilum, and from splenic hilum it goes into the your left paracoelic gutter. So this is the particular pattern of peritoneal current flow, and these malignancies form this pattern. So this is a systematic spread. This is not a erratic spread to anywhere part of diaphragm. So in these malignancies, maybe if we can tackle this part of the peritoneum, and then if there is a small microscopic disease remains after the peritonectomies, so some form of intraperitoneal chemotherapy can remove those disease. So with this concept, the concept of cytoreductive surgery and the intraperitoneal chemotherapy came in. So as of now, this is standard from some particular form of cancer, especially the epithelial ovarian cancers, colorectal cancer, some gastric malignancy, pseudomyxoma, and mesothelioma. Other than this, there are indications rarely in which there is a very limited peritoneal recurrence long after the primary surgery. So both in primary as well as recurrent setting, this when the recurrence is an isolated peritoneal recurrence, this concept of peritonectomies are coming up in a broad way. So we'll take a help of a PowerPoint presentation today to understand the basics approach and basic concept behind this peritoneal surface malignancies, and what are the treatment options available, how do we investigate, how do we say this peritoneal metastasis is operable, this is not, and what are the contraindication and complication of this type of surgery and chemotherapy. So I think with this basic idea, we'll proceed to the presentation. Any question beforehand from anyone? Okay, so to introduce peritoneal carcinomatosis as a term when there is a peritoneal metastasis from any intra-abdominal or extra-abdominal cancer, but this carcinomatosis term has been replaced by a peritoneal metastasis because as I've said that more and more these cancers are considered peritoneum as a loco-regional spread rather than a distant spread. So usually the peritoneal metastases have a very poor prognosis compared to the other metastatic sites. Suppose a colorectal tumor, if it is an isolated liver spread, then we can think some form of a curative treatment. But earlier, when there is a peritoneal spread from a colorectal cancer, it used to be a distant metastatic disease, and we usually treat it with either a best supportive care or palliative chemotherapy. So this was before this last decade when every peritoneal dissemination was considered as a metastatic disease, non-curable disease, and treated with the best supportive care or palliative chemotherapy. The problem with the treatment with best supportive care and palliative chemotherapy in this peritoneal malignancy is once there is a peritoneal metastasis, the absorption from the peritoneum decreases. So there is a recurrent ascites in these patients. So even if the patient is surviving for 1 year, 2 years, the patient suffering, the morbidity is very much. Patients having recurrent ascites, you have to put a long-standing drainage catheter or some form of a repeated aspiration paracentesis. So these would like to decrease the quality of life of this patient. So more and more this researcher has thought if some form of definitive therapy can be given to this peritoneal metastasis, maybe it is better response to the more than a palliative chemotherapy or a supportive care. So with this concept, the peritoneal neoplasm or peritoneal peritoneal metastasis has come into the picture. So basically, we can divide the peritoneal malignancies into a primary peritoneal malignant tumors or a secondary peritoneal malignant tumor. So primary peritoneal malignant tumor are mesotheliomas. So this can be a malignant mesothelioma, cystic mesothelioma, or a very well-differentiated papillary mesothelioma. Among this, obviously, this well-differentiated papillary mesothelioma has a very good prognosis. It's an indolent disease. Now, from the epithelial origin, there is a term called a primary peritoneal carcinoma. So, primary peritoneal carcinoma is a term which is very identical to an ovarian cancer, except there is no obvious ovarian tumor even in the final histopathology. So, there is a peritoneal metastasis. These are found in elder women with a recurrent ascites, but you don't find any primary. The concept or the hypothesis behind this that these are the tumors which originates from the surface epithelium of fallopian tube and spreads to the peritoneum. So these are also considered as a primary malignancy of the peritoneum. Other than some sarcomas and round cell tumors may happen primarily from the peritoneum, but these are not very common. Among the secondary carcinomas, ovarian carcinoma is one of the most common cancers which spread to the peritoneum, and also gastrointestinal like stomach, colon, other cancers also spread to peritoneum. And one important entity is a pseudomyxoma peritonei. We'll come little bit in details about these entities. So, though there are other form of peritoneal metastasis from breast, endometrium, lung, melanoma, cervix, adrenal, this type of tumors or cancers, but these are usually not considered as a loco-regional disease, and there is no particular form of curative intent therapy for this. Mostly for ovary, colorectum, stomach, pseudomyxoma, and this primary peritoneal malignant tumor is approached through a curable intent in care among the peritoneal malignancies. So the person behind this concept was a Sugar Baker. He was a pioneer of this all peritoneal surface malignancy in 1989. He defined that peritoneum is a loco-regional disease and not a metastatic process. So you can take a curative intent if the disease volume is low. So there are two essential components of treatment for this peritoneal malignancy. One is called a cytoreductive surgery. So that means you remove all the macroscopic visible disease by doing this peritonectomies. The second part of this treatment is a hyperthermic intraperitoneal chemotherapy. This is a form of heated chemotherapy which is circulated through a particular machine, pump generated machine, for a particular time in the peritoneal cavity after you have done this surgery. So basically, the concept behind the HIPEC is you have removed all the gross macroscopic disease, and for the microscopic disease, maybe this heated chemotherapy will act and will ablate this microscopic residual cancers. So this is usually done in the abdominal temperature 42 to 43 degree, and it is usually run for a 30 to 120 minutes. So the basic principle is to intraoperatively affect tumor cell kill by the process of diffusion of chemotherapy drugs into the residual tumor deposit. Because this heated chemotherapy forms this heat also thermally ablate those microscopic cancer, and also this increases the penetration of the chemotherapeutic agent into the peritoneum, into the abdominal wall or residual disease. What happens? It has been seen that the systemic chemotherapy, which is given through IV line, like your all cisplatin, IV cisplatin, IV doxorubicin, this does not act well for this microscopic peritoneal disease. People have seen that palliative chemotherapy for peritoneal only metastasis has very worst outcome. So maybe this heated chemotherapy is thermally ablating those metastases, as well as this increasing the penetration of the chemotherapeutic agent to this microscopic disease. So this was the concept behind starting this hyperthermic intraperitoneal chemotherapy. So for this hyperthermic intraperitoneal chemotherapy, the important part, just keep in mind that CRS comprises 90% of the treatment for this peritoneal malignancy or surface malignancy. HIPEC is for only the 10% residual microscopic disease is tackled by HIPEC. So the mainstay of treatment is CRS for a peritoneal surface malignancy. That is why only when the critical residual tumor cells is less than 2.5 mm, then only you will plan a HIPEC treatment. Above this volume, if they more than 2.5 mm, so this is unlikely, that is a quite gross disease, and it is unlikely to be affected by your hyperthermic chemotherapy. So if you can't achieve a good CRS, you cannot do a HIPEC. So for starting a HIPEC, the basic need is that you have to perform a very meticulous and good wise cytoreactive surgery. You have to remove all the macroscopic disease till 2.5 mm. Then only you are happy that you have removed all this gross disease, only the microscopic have remained, then only you will implement a HIPEC. So there might be situation when you have done only CRS, but your residual disease is something more than a 2.5 mm. There is in the vital or part of the body where you cannot operate more. So in those cases, you will not implement a HIPEC, you will do only the CRS and come on. There are other forms of some intraperitoneal chemotherapies, which the name you should be aware of. One is the EPIC, early postoperative intraperitoneal chemotherapy. That means you have done a CRS, you have closed the abdomen, you have placed multiple treens as an inlet and outlet, and on the postoperative day 1 to 5, you infuse the chemotherapeutic agent through the inlet and then keep it inside the abdomen, and then you wash out to the outlet. Then it can be a sequential intraperitoneal chemotherapy, that is called SIPC. So these are given through the intraperitoneal catheter with multiple cycles just after the surgery. And nowadays, there is a newer term that is called PIPEC, that is pressurized intraperitoneal chemotherapy. These are still in an experimental level and considered for extensive disease as an alternative to HIPEC. So now, what are the current indications for HIPEC? The current indications are colorectal cancer, in which the PCI is less than 20. I'll come what is a PCI. PCI is a peritoneal carcinomatosis index. This is a index which estimates the disease volume in the peritoneum. And according to the PCI, you will decide whether you will proceed for this peritonectomy or cytoreactive surgery or not. So colorectal cancer, recurrent colorectal cancers, gastric cancer with a very limited PCI less than 13. Ovarian cancer is one of the most common established indication of CRS. And then recurrent ovarian cancers also, you will, as a second line therapy in a interval debulking surgery, you can plan this HIPEC and CRS. Then pseudomyxoma peritonei, So this is one of the most important disease in which cytoreactive surgery is very effective, because there is no other treatment option available for pseudomyxoma peritonei. Chemotherapy does not respond well, and patient has a recurrent jelly-like ascites, mucinous ascites inside the abdomen. Recurrent ascites, where if you place drain to drain this fluid, this jelly-like mucinous fluid, it will not come out. So the patient has an intractable ascites. The only way to get out is you do a complete CRS if possible, and then you add HIPEC to these patients. Other than this, peritoneal mesotheliomas, also there is a role of CRS and HIPEC. So now we'll talk about some of these diseases in which some of these peritoneal surface malignancies in which the CRS and HIPEC has one established role. The most important one is a pseudomyxoma peritonei. This is also called a jelly belly, the presence of a gelatinous or mucinous ascites. This, most of these cases, this is a primary tumor of the appendix, or rarely it can be ovarian mucinous cancer. The spectrum ranges from a very low-grade tumor, which is called diffuse peritoneal adenomycinosis, DPAM, to a very aggressive frank adenocarcinoma called the peritoneal mucinous carcinoma. So there is different terminology for pseudomyxoma peritonei depending on the grade of the tumor. If it is a low grade, it is called diffuse peritoneal adenomycinosis. It is not considered as a malignancy, but it can be a very rarely it can be a malignant, an aggressive malignancy like a peritoneal mucinous carcinoma. So the conventional treatment used to be a repeated drainage of mucin, debulking surgery with a 5-year survival almost 6%. When Sugarbaker implemented the cytoreactive surgery for the first time for pseudomyxoma peritonei, the 5-year survival increased up to 86% patients with low-grade tumor. And also in this other papers, other studies has reported there is a very good survival, 5 and 10-year survival, 87 to 70% in this pseudomyxoma peritonei if you can achieve a CC0 or 1. This is a completeness of cytorejection score. That means how effective is your surgery? Have you removed all the disease? So if you can achieve a good cytoreactive surgery, remove all the peritoneal deposits, all the bowel serosal deposits, then you can achieve a survival of 87% from a survival of 6% through with the help of palliative chemotherapy. So next indication was a colorectal cancer. This is the second most cause of the peritoneal metastasis is the second most organ of metastasis after liver in colorectal cancer. So 10% CRC have a peritoneal metastasis at presentation, and 25% will develop as a metachronous after the resection of the primary tumor. So with this help of CRS and HIPEC, the survival has increased from a palliative, because in colorectal cancer, if you have a peritoneal metastasis, the earlier protocol is you just give palliative chemotherapies to this patient, that the survival is around 10-12 months maximum. But with the help of this cytoreactive surgery, now the survival in this stage 4, that is colorectal cancer with peritoneal metastasis, can be around 20 to 25 weeks. It has almost doubled with the help of this. So basically, but in colonic cancer, advocated PCI, peritoneal carcinomatosis index, is less than 12. So this is the patients who have a very limited peritoneal metastasis will have a greater chance to be cured from cytoreactive surgery. And your surgery should be a good one, that is a CC0, and there should be a good response to a systemic chemotherapy. These factors, if present, then there is a chance that this patient will have a long survival even after they have a stage 4 colorectal cancer. Now, ovarian cancer, 75% of all ovarian cases are diagnosed in 3rd or 4th stage. But if you see the staging of ovarian cancer, rest in all cancers, peritoneal metastasis is stage 4, but in ovarian cancer, peritoneal metastasis is considered as stage 3 because it's still considered as a curable disease. So the treatment of ovarian cancer comprises of CRS followed by systemic chemotherapy, the usual previous treatment, but it has a very poor 5-year survival, around 30%. So now there are increasing evidence that intraperitoneal, maybe simultaneous intraperitoneal chemotherapy may help. Then the role of HIPEC came into the ovarian cancer. mostly in the line of second line therapy in the IGS setting. What happens ovarian cancer if it is a there is two terminology in ovarian cancer. One is a primary debulking surgery and a interval debulking surgery. That means if it is a very operable disease, you first operate in ovarian cancer and then you add adjuvant chemotherapy. But if it is a very widespread metastasis, what you can do, you can use same chemotherapy as a neoadjuvant chemotherapy for 3 to 4 cycles, and then you operate this patient. So these patients are termed as an interval debulking surgery, and this patient has maximum results from HIPEC till now. What evidence we have, interval CRS and HIPEC is now one of the gold standard surgery treatment for ovarian cancer. For primary HIPEC, primary CRS that is recommended, but primary HIPEC there is little doubt in the evidence till now. So this is about ovarian cancer. Now in gastric cancer, obviously this is also one of the most common cancer which presents either synchronous or with metachronous peritoneal malignancy. So most of these cancers till now is treated with a palliative treatment, but this HIPEC has been introduced in gastric cancer also. When the peritoneal spread is limited, less than 13, then we can think of a cytoreactive surgery and then hyperthermic intraperitoneal chemotherapy in gastric cancer also. Mesothelioma, which is a very rare disease, which is linked to asbestos exposure, and this occurs in the serosal surface of pleura, pericardium, or peritoneum. Now, CRS and HIPEC shows us that there is a durable control of ascites because this patient, because it's a primary cancer of the peritoneum, presents with recurrent ascites, but with the help of CRS and HIPEC, the ascites control of ascites is much more better than these chemotherapies. Though there is no great improvement in the survival of this patient, but the quality of life of this patient goes better with CRS and HIPEC. And some good prognostic factor epithelial subtype, lymph node negative disease, complete cytoreduction. So in these cases, HIPEC may help to increase the survival for some patients. Other rare indications can be ovarian primary tumor, this neuroendocrine tumors and sarcomas. For any type of these tumors, any cancers of any peritoneal surface malignancy, the most important significant prognostic factor is the PCI and the completeness of cytoreduction score. So your PCI score and CC score is the most important prognostic factor. I'll come to the scores in details. Now, if we find a patient with or a suspected patient with who have a colorectal cancer, ovarian cancer, or a gastric cancer with peritoneal metastasis, so how will you investigate this patient? What imaging you will do? So the goal of the imaging that you have to rule other distant metastasis. If a colorectal cancer presents simultaneously with liver metastasis and peritoneal metastasis and lung metastasis, these are not a candidate to do a peritonectomies or CRS. Only peritoneum only metastasis is there, then only you will think of this disease because you are considering peritoneum as a loco-regional organ. So if there is only spread limited to this peritoneum, then you will think of doing this CRS. So you have to rule out the distant metastasis. You have to rule out the inoperability. Maybe the PCI is low, there is peritoneal only spread, but there may be some deposits in some part of the porta or somewhere else where it is not operable. It is technically not feasible to operate this patient, route of mesentery. So this you have to exclude through your imaging that this can be technically operated. And also you will quantify the extent of disease by predicted PCI through your radiological imaging. So ultrasound obviously not a very sensitive tool. CT is usually done in most of the cancers. CT is the baseline tool that is with oral and intravenous contrast. This is the imaging modality of choice, but the sensitivity of the CT scan to detection of peritoneal deposit less than 1 centimeter is very low. That is when the picture of MRI came, and recent years diffusion weighted MRI is specifically useful for detecting peritoneal metastasis and bowel surface deposits along with mesenteric and omental deposits. So this is a very important useful investigation in diffusion weighted MRI to interpret this peritoneal, momental, or mesenteric deposits. So, rate of detection of peritoneal matter less than 1 centimeter is better with the diffusion weighted MRI than CT scan. But this again, having said that, that MRI, diffusion weighted MRI is one of the most important and most gold standard investigation for peritoneal carcinomatosis. The logic against it is that there are not many radiologists who is very versed with identifying this peritoneal, small volume peritoneal metastasis from diffusion weighted MRI. It needs a training, and it needs to dedicated work in a cancer center to understand that from the MRI what can be the peritoneal why peritoneal metastasis can be present in a small volume. So basically there are some signs like appearance of ascites if there, so that may suggest that peritoneal metastasis may be there. The abnormal enhancement of the peritoneum, there is subtle thickening in the peritoneum with fine reticulonodular pattern and nodulity along the peritoneal surface. These things may suggest this radiologist to understand the chances of peritoneal metastasis. Now, the role of PET-CT is still debatable, but PET-CT can exclude distant metastatic spread like lung or nodal spread. So, if you are planning for a CRS, but there is a high volume disease in the peritoneum, you are not sure whether any other lung mets or lymph node mets are present. So you can go for a PET scan to rule out that it is only peritoneum only metastasis. So basically, before you planning for a surgery, you can take a PET scan if your disease volume is high. Now, this peritoneal metastasis detection improves with the use of oral contrast in CT and MRI. So that can help to identify the small wall serosal involvement. So now, what are the other things you should look for? This is about this exclusion of the distal metastasis. You can take care of the PET scan or your CT or MRI. Now, and also you will measure the extent of disease of your predicted PCI. You will get from your CT scan or MRI. But what should you look upon more is the signs of inoperability. So if there is extensive involvement of the small bowel or root of mesentery, if there is lymph node along the celiac axis, if there is thoracic involvement like pleural effusion or lung metastasis, if there is a pelvic sidewall invasion, bladder trigone involvement, parenchymal liver metastasis. See, there is a visceral peritoneal covering over the most of the part of the liver that is called a Gleason's capsule. So there can be some deposits over the Gleason's capsule, and you can remove the peritoneum with the help of Gleasonectomy. But those are called subcapsular liver implant. Capsular liver implant. But if there is a intrahepatic parenchymal liver metastasis, or there is a subcapsular liver implant close to the main vessels in the liver, so those are considered as an inoperable disease. So now, what is the role of laparoscopy in CRS, and before you consider the patient for this extensive surgery? Should you do a diagnostic laparoscopy? Should we, because CT and MRI, those are not 100% to rule out the disease volume and the technical feasibility of the surgery, whether it is technically possible or not. So should we do a diagnostic laparoscopy before we go for a incision, ziphistern, to symphysis pubis, to open up whole of the abdomen and do this peritonectomy? So definitely laparoscopy has come into the picture, but there are some pros and cons. So what has the disadvantage of laparoscopy is that trocar positioning may be difficult because there may be a high volume peritoneal disease. So you may not, there may be mucinous ascites like pseudomyxoma, where you don't have a proper chance to place a trocar, and there can be an injury to the bowel and other organ. And through laparoscopy, because some of these diseases sometimes deposits in the visceral peritoneum of the porta or small bowel mesentery or in the foramen of Winslow, to evaluate all these critical areas through laparoscopy is sometimes difficult. So the reliability of evaluation for a complete staging is a concern. And also there can be contamination of the port site through the laparoscopy. That is why laparoscopy ultimately has not come up with a big role in a cytoreactive peritoneal malignancy. Retroperitoneal structures cannot be evaluated properly with laparoscopy because if you're planning for a cytoreactive surgery in HIPEC, it's an 8 to 10 hours procedure. So you have only very limited time to do your diagnostic laparoscopy. So you cannot just go on doing this diagnostic laparoscopy and then plan for a larger surgery. So basically, one score has came up that is called Fagotti score in laparoscopy for peritoneal malignancy. So this gives you a predictive index value, and this score this scoring can be done, and this score sees 7 sites of disease. The sites are being peritoneum, diaphragm, root of mesentery, omentum, small and large bowel, stomach, and liver. And according to this, scoring has been done. And if the score is more than or equal to 8, there is a high chance that it will land up into a suboptimal or an incomplete surgery. Now, coming to the PCI scoring, or this is also called a Sugar-Baker's classification. So, this classification depends on the location and the lesion size. There is 2 factors. One is the location and one is the lesion size. So in this classification, abdomen has been divided into 9 sectors and small bowel into 4 parts. If you can see this image, this is quadrant 0. Now 1, 2, 3, 4, 5, 6, 7, 8. So 0 to 8, 9 segments, and the small bowel can be divided into upper jejunum, lower jejunum, upper ileum, and lower ileum. Now, if you go through the lesion score, the lesion score is, you will estimate every quadrant, how much the lesion size is. And depending on each quadrant, the highest lesion size, you will assign a score to this particular organ. And this lesion score is lesion score 0 when there is no tumor, lesion score 1 when there is tumor up to 0.5 centimeter, lesion score 2 when the tumor is 0.5 to 5 centimeter, and lesion score 3 when it is more than 0.5 centimeter. Now, suppose you are dealing a case of your right colonic cancer, sickle malignancy with a limited peritoneal metastasis. Now, suppose you have done this laparotomy. Now, you will plan your PCI score. So, suppose the tumor in the right side of right lower abdomen, the primary tumor is present, and this is a large tumor around 6-7 centimeter. So the right lower quadrant goes a score of 3. Now, right flank, there is a peritoneal metastasis, but these are 2 to 3 centimeters, so the lesion score 2. And the pelvis, there is also some deposit, but those are less than 0.5 centimeter. Now, you have left upper quadrant 0, epigastrium 0, left flank you have 0, left lower quadrant you have 1, right upper and central is 0. And in upper jejunum, there is bowel surface deposits. So it is small, 1 to 2 centimeter. So in upper jejunum, we will find the lesion score 2. Lower jejunum 1, ileum 0, 0. So suppose this is your spread distribution of the peritoneal carcinomatosis in a hypothetical right colonic malignancy, and there is spread to the pelvis, there is a spread to the left lower quadrant, there is a spread towards right upper quadrant or diaphragm, and there is also spread to the right flank, and some bowel surface deposit in the jejunum, not in the ileum. So then you will calculate the PCI, you will add up all this score, and the 1 plus 1, 3, 3, 6, 8, and 3, 9. So your PCI will be 9. Okay. So that is how your, 3, 3, 6, 8, 10, 11. Your PCI will be 11. So that is how you calculate the PCI. So you will see all these quadrants and the bowel, your small bowel segments, and you will assign a score according to size in and you will assign a score according to the lesion size. So that is why your PCI is calculated. This is ideally calculated when you do the exploratory laparotomy, laparoscopy, and preoperative radiological imaging can only give you a predicted PCI. The original PCI is calculated when you explore the abdomen. You have made the incision from Ziphis to symphysis pubis, open up the abdomen, you see whole of the abdomen quadrant-wise meticulously, and then you write down your PCI on your operative notes. So any confusion regarding this PCI score, because this is one of the most important aspect of peritoneal malignancy you need to understand. Before I go ahead with another score, that is completeness of cytoreduction. Any doubts? Okay, I think everyone has understood. Now the second score, which is most important, another most important score, is completeness of cytoreduction score. So this is basically your success of surgery, your quality of surgery evaluator. This is also a major prognostic factor. So in this, the concept is you're not every time your absolute R0 resection is necessary, or it is not possible sometimes. So depending on the residual tumor volume, how many, what volume of tumor you are leaving. So there is a classification, the CC classification. So CC0, when there is no visible peritoneal disease after the cytoreductive surgery. CC1 is when your residual volume are less than 0.25 centimeter or 2.5 millimeter. CC2 is when there is quite a gross disease, that is 0.25 centimeter to 2.5 centimeter. And now CC3 is you're almost like R2 resection when you have left more than 2.5 centimeter disease. So the aim of the cytoreductive surgery is to achieve either CC0 or still CC1 is acceptable. CC2 and CC3 means an incomplete surgery or a non-curative surgery. So if one has to consider peritoneectomy with HIPEC as a curative intent treatment of peritoneal carcinomatosis, patient who cannot be classified as expected CC0 should be excluded from the procedure. So the basic initial concept, only when you are doing a CC0 resection, no visible peritoneal settling, then only you use HIPEC, otherwise don't. But after that, it has with the more and more patients recruited into the studies and more data came in. So it has seen that CC1, that is residual disease between 2.5 mm to 0.25 mm to 2.5 mm, HIPEC may be curative in some patients of this. So CC1 also considered as a candidate for HIPEC, but CC2 and CC3, in those cases, they are a gross residual. This is an incomplete surgery, so you don't use a HIPEC in this patient because HIPEC has its own complications and it will increase the morbidity of the surgery more and more. So these are considered as advanced palliative surgery. Now coming to the prognostic factor, obviously the histopathology is the most important factor. If you are dealing with a DPAM, that is diffuse peritoneal adenomyosis, that's obviously if you have done a CRS, complete CRS, CC0, CC1, then your prognosis is excellent. Patient may live for 5-10 years. But if you are dealing with a frank adenocarcinoma, peritoneal carcinomatosis from colonic cancer or a appendicular pseudomyxoma, then the survival may not be that long. Then the second is a peritoneal carcinomatosis index, which we have described in details. Then your completeness of cytoreductive score, and obviously the TNM staging that will and peritoneal cytology that will play a central role because ultimately all the patient's prognosis mostly depends on your histopath and your initial staging. So now coming to the surgery, cytoreductive surgery with the principles and techniques. So cytoreductive surgery deals with macroscopic disease and intraperitoneal chemotherapy acts as on the microscopic disease. The goal of CRS, as I have told, to remove all the deposits more than 2.5 millimeter in size. For any tumor that spread in a particular area of peritoneum, not just the segment of the peritoneum, but the peritoneectomy corresponding to that region should be performed. That means if you have a small deposits on the right diaphragm, 1-2 small deposits, you just can do a wide local excision of that peritoneum, but it is not recommended. Once there is a spread in a particular organ site, those 9 sites mentioned in the CRS PCI score, so you just remove the peritoneum of that particular segment. So that is what is recommended for cytoreductive surgery. And Sugarbaker advocates some use of high voltage electrocautery, and that is also called a ball tip cautery, and for doing CRS that helps to remove the peritoneum from the sheaths in your um, in inner layer of the rectus sheath. The peritoneum has to be removed during the surgery, and any isolated tumor nodules which cannot be surgically removed, suppose it is sitting on the ureter or it is sitting over some vessel, can be electrovaporized with the help of this high voltage electrocautery. So what are the types of peritoneectomy we deal with while we are doing this cytoreactive surgery? It can be anterior parietal peritoneectomy, that is the peritoneum lining of anterior abdominal one bilaterally extending to up to the line of Tolles. So from one side of left colon, one side of colon reflection of line of Tolles, peritoneal reflection side of the colon to other side. So that means the whole of the anterior abdominal wall peritoneum should be removed. That is called an anterior peritoneal anterior parietal peritoneectomy. Then it can be a left upper quadrant peritoneectomy. That means your left diaphragm, hemidiaphragm peritoneum has to be removed up to the falciform ligament. Then it can be a right upper quadrant, that is the peritoneum of the right diaphragm, extending from the falciform to costal margins. Then it can be a pelvic peritoneectomy. That means all the peritoneum and the brim of false pelvis over the bladder surface you have to remove, and up to the inferior mesenteric artery. And there is bursectomy. The bursectomy means that there are visceral peritoneum lying over your hepatorenal pouch of Morrison, your foramens of Winslow, lesser your gastroduodenal and hepatoduodenal and hepatogastric ligament, that is your lesser omentum. So all the visceral peritoneum overlying this part should be removed if there is a deposit. Sometimes there is a surface deposits over the liver, so you have to do a glycinectomy. That is, your liver capsule has to be removed, and in all this peritoneal surface malignancy, usually your omentectomy is an integral part. The total omentectomy is required because omentum is a potential site for metastasis also. Other than this, if you have a deposits on the small bowel mesentery or the small bowel serosa, that you have to remove individually. If you're dealing with ovarian cancer, then and most of these primary peritoneal cancers, you will do a KHPSO because that may be the culprit origin, this fallopian tube of this malignancy. If you are dealing with a mucinous tumor, it is recommended to go ahead with appendectomy. So all the organs where from the mucinous cancer can generate is usually removed when you are dealing with a mucinous cancer. And all the peritoneum, both visceral and parietal, is removed if there is a deposit. So this is performed through a thorough exploration of the abdominal cavity in midline laparotomy incision from xiphoid to pubis. There are two approaches. One is called extraperitoneal approach. That means you cut in the midline, you cut the skin, anterior rectus sheath, posterior rectus sheath, and then you don't open up the abdomen. You just splay away your peritoneum from the posterior rectus sheath, and bilaterally you reach up to the line of Tolles, and then you go downwards towards the pelvis where the peritoneum also reflects. So all the parietal peritoneum you will remove in toto, but doing an extraperitoneal approach is very difficult sometimes because of this technical difficulty approaching the pelvis or diaphragm. So most of the surgeons prefer the intraperitoneal approach. That is, you open up the peritoneum in the midline, and then you remove quadrant-wise in which quadrant this peritoneal metastasis is present. The concept is you deal with the difficult area early, so that you will, because it's quite a long surgery, 8 to 10 hours it will take if you do a complete cytoreaction and HIPEC. So you first do the difficult area. So what is recommended that the first step is you assess, you write down the PCI, then you remove the omentum. So now once you remove the omentum, the secretions will decrease. So there will be, the surgical field will be clearer. Then you focus on the upper abdomen. You do the right diaphragm. If they are, you remove the metastasis on the hepatorenal pouch of Morrison. There is your lesser sac, that means your gastrohepatic or gastroduodenal ligament. You remove the peritoneum of the HRPM, but you see the porta. If there is a portal surface deposits, remove them early. Then you go for the spleen, see the whether there is splenic hilum deposit, whether you have to do a splenectomy or not. If there is a gross splenic hilum deposit, many a time you will land up with a splenectomy. What happens? This peritoneal current flows from the pelvis towards the right paracolic gutter, then goes to the right diaphragm. Then it enters through the foramens of Winslow and goes along the pancreas, scale of pancreas to the splenic hilum. So many a time your left diaphragm got spared. So even if there is a high volume metastasis, it's very rarely expressed to the left diaphragm. So many times this left diaphragmectomy is not done because there is no deposits. So you have to go in a systematic fashion in a clockwise manner, we call. So you start with the right hemidiaphragm, do with the visceral peritonectomy of HRPM, lesser sac, your gastropetic gastrodenal ligament, porta, you clear. Then you go to the left diaphragm if there is any, or you go to the splenic hilum, clear it, go to the left parietal peritoneum, then go to pelvis, do the pelvic peritonectomy, do that your hysterectomy if necessary, remove the peritoneum over the bladder, then come back to the right lower quadrant, remove the right parietal peritonectomy, and you then go ahead with looking for the mesenteric or bowel surface deposits. Sometimes bowel is involved with this surface deposit. Most of these tumors are surface deposits. So many times you will do a surface dissection over the bowel. Even if there is a bowel serosal deposits, you can remove it with the help of fine your sharp dissection. But if the deposit is very large, it is compressing the bowel. So many times you may have to do a resection anastomosis or a partial resection and primary repair. So the important aspect is it should be done through a trained team, and there should be 2 teams available because it's a long-standing procedure. One surgeon may got fatigued, so it should be combined as a group approach. If these gynecological oncologists are performing these procedures, the GI surgeons, the GI oncosurgeons should be present. So if there is this need of bowel dissection, because sometimes this ovarian, when you are dealing with ovarian cancer, it involves the rectosigmoid very frequently. So low anterior dissection may be needed. Even in disseminated disease, you may land up into total colectomy also. So if only there is a infiltrative disease in the porta hepatis, if you are dealing with, especially with ovarian or a pseudomyxoma, where in any PCI, cytoreactive surgery is recommended. In colon and gastric, there is a limitation. If there is a disseminated metastasis, the PCI is more than 13, 15, it is not usually gives some survival advantage. But in ovarian and pseudomyxoma, if the surgery, cytoreactive surgery is the only option the patient have. So if you can remove the disease, all disease, so you can do a total colectomy, you can do a partial segmental small bowel resection. So the only contraindications to cytoreactive surgery in these cases where like ovarian or intervallical debulking surgery or your pseudomyxoma peritoneal is infiltrative disease in the porta. If the root of the mesentery is involved, so whole of the small bowel will get compromised if you resect that tumor. If there is an extensive bowel serosal surface deposit, so you cannot do at least you cannot maintain a 100 to 150 centimeter of the small bowel. And if there is a parenchymal liver deposits, so these are only contraindication to cytoreactive surgery in case of pseudomyxoma and interval debulking, where CRS is only option you have. So go in a systematic fashion, make a group of surgeons who are trained in peritoneal surgery, CRS team, and then you proceed for doing this extensive surgery. So this is a picture which shows the different types of bowel deposits. So it can be a very small deposit like this, which can be just shaved off from the bowel with the help of sharp dissection. This can be little in partial involvement of the bowel serosa, where you can just remove and primarily repair this defect. It can be a full thickness bowel involvement, or you can just do a resection and without the resection of the mesentery and canalostomos. If this is a deposit towards the mesenteric surface, you have to cut a portion of the mesentery and anastomos. And if it is a large deposit, you have to go for a segmental resection. So this is just to give you the idea that there are many types of disease, but what your goal is to remove this disease, preserving as much as small bowel possible. So when you are dealing with a high volume disease like in interval debulking surgery or pseudomyxoma, so what are the things you will try to preserve? Is you try to preserve the proximal 1/3 of the stomach, at least 3 meters of the small bowel, or 2.5 meters of small bowel if there is a colon is remaining, at least for 30 to 50 centimeters. Protective ileostomy should be performed if 2 or more anastomosis has been done, or if you are going for a HIPEC, so there may be more chances of bowel anastomotic leak. So in those cases, especially for the beginners, it is better to do a protective ileostomy if you're doing 2 or 3 anastomoses or even single anastomosis with a HIPEC. But this is not mandatory. Which are expert center, they have a very decreased rate of protective stoma. The complication rate is over 7 to 20%, and the most common complication is usually bleeding. Sometimes the patient will have a pleural effusion. So usually because of all that peritoneum has been removed, the absorptive capacity of the peritoneum decreases. So there is a fluid sequestration. So there is a high drain output from the ascitic fluid. Sometimes some surgeons will put a prophylactic intercostal chest drain, especially after HIPEC, where there is a intense reaction to chemotherapy. Sometimes there is during this diaphragmatic peritoneectomy, the diaphragm may open up. So you may have to repair the diaphragm either primarily or with the help of a mesh. So it is basically extensive surgery. You have to remove many important vital organs. It's a very long surgery. It needs a dedicated team in oncology center. And HIPEC, you have to always keep it side by. And only after you have achieved the CC0, CC1, you will implement HIPEC. And HIPEC is also a very costly business. Each and every HIPEC in HIPEC set, this consumable circuit through which the peritoneal fluid and chemotherapy circulates, costs around 70 to 80,000 in Indian made product. In foreign made product, it is around 1 lakh for each patient. So that is very high costly thing. So you are preparing for a HIPEC, you have run the machine, but ultimately you may not need the HIPEC if you can't achieve a CC0 or CC1. So there is a controversy between whether should you do a bowel anastomosis before or after HIPEC. If you're doing a before HIPEC, the disadvantage is that there can be mechanical traction during this perfusion chemotherapy and this HIPEC circulation of chemotherapy, or there can be integrity of the anastomosis may get lost with the effect of heated chemotherapy. If you're doing an anastomosis after HIPEC, the disadvantage is there will be bowel edema due to this heated chemotherapy, so technically more difficult. So hyperthermia, how it helps in cell killing, so direct cytotoxic effect, and also it enhances the tissue penetration of the chemotherapeutic drug. The usual range HIPEC is around 90 minutes, it varies from 30 to 120 minutes, and there should be a carrier solution for this chemotherapy. So peritoneal dialysate fluid is mostly used with the chemotherapy to circulate the chemotherapy inside the abdomen. So the rationale is HIPEC is to uniform distribution to all the part of the peritoneum, and only when your residual disease load is minimal, you will give. So it will give a high concentration of chemotherapy to the residual microscopic tumors. So HIPEC can be done in 2 methods. One is open methods and closed methods. So open is basically you will put up this retractor, and you will put you'll retract the abdominal wall. You will make like a what you can say it's a small well or a small bucket, and then you give the chemotherapy and drug, and you will circulate. The machine will start circulating. So this is called open method when the abdomen is open, but there is problem. These heated fumes will be all over the operation theater, chemotherapeutic fumes. So another method is a closed method. When you after the CRS, you have put these catheters inside, place this catheter properly, and then you close the abdomen temporarily, and you start this machine, your pump with the chemotherapy. So the heated chemotherapy will circulate inside the abdomen, and after your particular time, you will remove these stitches and again open up the abdomen, wash it, and complete your anastomosis and complete your surgery. So complications it's a very difficult surgery, and there are complications. So chemotherapy toxicity is there, especially cisplatin, which is used in ovarian cancer in a very large scale, cause a nephrotoxicity. Hypothermia can also cause organ damage. Intraoperative monitoring of this cold temperature is very necessary. Sometimes you have to give cold salines. Patient has to be during this HIPEC phase. All these your axilla, neck, all has to be packed with cold ice or cold saline bottles. All the IV fluid should be very cold. There can be need for insertion of the nasogastric tube, and cold fluid has to be run through the nasogastric tube. So there is a effect of hypothermia that may complicate these patients. Yeah, surgical complications are there. Most common of them being bowel fistula, and mortality is around 5% of this procedure in a trained institute. So contraindications to see other than surgical contraindications, chronic disease, which because this surgery is very, and this HIPEC, all are very toxic therapies. So you have to choose this patient very wisely. Only with good performance status, without comorbidities, you will do this. Total cystectomy, when the patient will this ovarian tumor or colorectal tumor has infiltrated the bladder trigon, so it is not possible to do a R0 CC0 resection without a total cystectomy. In that situation, it is not recommended to perform a CRS and HIPEC, because it has seen that does not give any oncological advantage. Obviously, you will have, if you have extra abdominal metastasis like peritoneal lymph nodes, that means it is a and it is not a peritoneal only metastasis. So in those cases, it's better to avoid. So these are usual the contraindication. And the last slide, which I will highlight, that what is the role of laparoscopy in CRS and HIPEC? Obviously, staging laparoscopy, diagnostic laparoscopy you can do to assess the PCA status, predict PCA and operability, that is called Fagotti score. Laparoscopic risk reducing surgery, what you can do a laparoscopy if you have a very limited amount of disease, like small early ovarian cancer with limited peritoneal metastasis. So you can just go ahead with laparoscopy. And sometimes you have an intractable ascites, and there is a patient's quality of life is very poor. So where you are sure that you cannot complete CRS, you cannot achieve CC0, CC1. So in those cases, you can do this laparoscopic CRS and HIPEC, so that the ascites and some form of developing will be done, and the patient will be free of, the patient will be have little better quality of life, though you are not surviving you are not increasing the survival of this patient. You acts as a palliative procedure to increase the quality of life, especially in pseudomyxoma peritonei, where multiple times that patient has a jelly belly, the mucinous ascites, the drain will not trade. So maybe some laparoscopic debulking or drainage may help to reduce the symptom. So with this, we'll complete the presentation. I know it's a very exhaustive topic and it's a difficult topic to understand for you guys, but just keep in mind that this PCI score, CC0 score, and the basic concept behind peritoneal surface malignancy, what you need to understand and remind.
Sir?
Yeah.
Sir, in all cases of peritoneal carcinomatosis, is appendectomy and total abdominal hysterectomy done in all cases?
Yeah. No, not in all cases. If you're dealing with it depends on what is the primary is. If you're dealing with a ovarian cancer, so if it is a mucinous cancer, then only you will do appendectomy. If it is a serous cancer, so appendectomy is not recommended. The concept is that appendix is a site of mucinous malignancy, mucinous adenocarcinoma. So there may be a chance that you are suspecting these patients as ovarian primary, but there is a chance that it has originated from appendix and it has spread to the ovary and other part of the peritoneum. So in those cases, and obviously if you are doing for pseudomyxoma peritoneum, you have to do appendectomy. And if you're dealing with other mucinous cancers, for gastric cancer, for colorectal, if you're doing suppose you're doing a peritoneal CRS for a left colon cancer, it is not mandatory to do a appendectomy until unless it is a mucinous variety of cancer.
So hysterectomy also done if there is primary tumor in the uterus only?
No, uterus never for uterine cancer. You will say if it is a ovarian cancer, or a primary peritoneal malignancy in which you are suspecting that the fallopian tubes are the culprit. What is a primary peritoneal malignancy? As per radiology, as per histology, as per ISC, everything is same as ovarian cancer. But the GOG criteria for primary peritoneal CA is you will not find any tumor on the ovaries. So the hypothesis behind this may be the fallopian tube surface epithelium has gone changed into a malignant epithelium, and that has spread to the peritoneum because this fallopian tube resides nearby the peritoneum. So in those cases only you will do a hysterectomy. For a colorectal, it is not mandatory to do a hysterectomy. But if it is a female patient, and most of these patients will be elder patients, so and if you have a disseminated peritoneal metastasis, there is a high chance there will be rectovaginal pouch deposit. There is a deposit on the surface of the ovaries. There can be deposits over the surface of the uterus. So if it is the family is completed and your childbearing age is completed, then most of the time the surgeon performs a hysterectomy because they want to exclude any possibility of this primary fallopian tube or ovarian cancer. But if that is a fertile patient, because these patients will undergo chemotherapy, anyway, they are not going to be fertile after all these toxic treatments. So that is why it is. But for a gastric cancer or for a left colon cancer, if you're doing that, and if there is no ovarian deposits, no your POD, pouch of Douglas deposits or uterine surface deposits, so you may omit this if you are very certain of your diagnosis.
Okay, sir. Thank you, sir.
Any more questions?